We're good?
I don't know why, because they never asked us for anything in addition to what they had.
I'm going to introduce her to Stacy.
Hey, sir.
How you doing?
Good, sir.
All right. All right, it's 1 o'clock, and I'd like to call the Health and Human Services Committee of the Mecklenburg County Board of County Commission to order. We have two of our members, Elaine Powell, Commissioner Powell is on the way, and Commissioner Laurel Myers is also on the way. And when they get here, we'll take that one action item of approving the minutes. But since the staff's here, we'd certainly like to go ahead and start our committee meeting. So with that said, I'd like to introduce the two of us that are here. My name's Arthur Griffin. I chair the Health and Human Services Committee of the board, and my colleague.
My name is Vilma D. Lee, and I represent the most powerful district in the county. And I'm grateful to be a part of this committee and to still yet be alive. Where are these people? Powell is always late.
All right, Commissioner, let's stick with the agenda here. Next on the agenda
That's part of
is
the agenda. You need to be here on time.
the next part of the agenda. I will introduce our staff and our guests. For that, I'll reach out to our Deputy County Manager, Mr. Trotman.
All right. Good afternoon, Commissioner Griffin, Commissioner Leak. We have a good agenda for you today. We have two presenters. Dr. Washington will present on maternal health programs in our county and specifically talk to you about infant mortality. And we also have a guest with us, Shanavia Montgomery, who's the CEO of Caring. And she's going to talk to you about two county-funded programs that focus on the same population.
Thank you very much. Other staff, please introduce yourself.
Good afternoon. I'm Stacy Lowry. I'm the Director of Community Support Services.
Good afternoon, Taya Cruz, Assistant to Anthony Trotman.
Hey, good afternoon. Robert Nesbitt, Chief of Staff for the Health and Human Services Agency.
Good afternoon. I'm Fonda Clifton, Child Support Enforcement Division Director, standing in the absence of Yolanda Griffin.
Good afternoon. Raynard Washington, Public Health Director.
All right, our guest.
Can't hear you.
Good afternoon, I'm Megan Montgomery from the County Manager's Office, Strategy and Planning Analyst. Stephanie Montgomery. Afternoon, Eliza Durfee, Analyst and Strategic Planning Evaluation.
I didn't hear the last part of your statement.
I'm a Senior Analyst in Strategic Planning and Evaluation.
With which department?
With Monica.
Dr. Allen.
Oh, so you're not sitting next to her?
So we got some stuff on this chair here.
I'm kidding.
Storage.
And our guests,
Yes, Shanavia Montgomery, CEO and Caring.
all right.
I'm Alex Burnett with Public Information.
Thank you all for being here. I think Commissioner Leak is familiar with the fact that I like to start on time and I like to appreciate the staff's attention to detail and being here. This is an extraordinary, important topic today. For those of you who keep up with healthcare, particularly from an African-American perspective, we're ending our National Week of Black maternal healthcare issues in the country. That was announced by the National Health and Human Services, our federal government. So this is an important task, and I certainly I'm eager to hear the presentations that will be made. Oh, okay, here's our other commissioner. Please introduce yourself.
Good afternoon. I am Mecklenburg County Commissioner Elaine Powell, and I'm happy to be here.
All right, now we can actually take an action item, and that is the chair will ask for a motion for approval of our minutes.
So move, Mr. Chairman.
Second,
It's been properly moved and second. Any discussion? Hearing none. All those in favor say aye.
aye.
Motion passes unanimously. Thank you.
Question.
You have a,
Mark Terrell, is he still on this committee?
no, ma'am.
When did he remove himself?
He didn't remove himself. I think last year or at the beginning of this year, the committees were assigned and sent out to all of the members of the Board of County Commissioners, I think, and to staff.
And his name was
That-
on here.
Right, that is correct.
Didn't know that.
I'd like to move now to Mr. Trotman, if you will introduce this first topic of maternal health programs in Mecklenburg County.
Thank you, Commissioner. It is a topic that is associated with one of the board priorities, access to care as well as early childhood development. And it's also something that we've discussed in the past around infant mortality and the impact on our community and the causes of it. And Dr. Washington will give you details of that as well as programs that we have to combat it. So Dr. Washington.
Thank you, sir. I'm going to ask for a little bit of grace because I am recovering still. So if you hear me take a cough or a pause, just bear with me. But good afternoon. It's certainly great to be here, Chair Griffin, and to the committee members to talk a little bit about maternal and child health as it relates to Mecklenburg County and the work that we do in the health department. As Deputy County Manager Trotman just mentioned, I am intending to do two things. One, provide a little bit more context about infant mortality in terms of what's happening with infant mortality in Mecklenburg County. And two, talk a little bit about the programs that we currently have that address it. And I will caveat that most of our programs are what I would deem mandated programs, meaning that these are initiatives that are mandated or have been started initially by the state that we administer on their behalf here in Mecklenburg County, but work to address issues related to maternal and child health. And so I'll identify those that are mandated, those versus those that are not, and share some context around the reach of those programs, and look forward to sharing more about where we're headed in the future at the very end. So with that, I'll get started. All right, looks like the clicker's not. Oh, wonderful. All right, so just to level set, overall infant mortality in Mecklenburg County, infant mortality for just to level set with everybody is the death of a baby before their first birthday. Any baby who dies before their first birthday, regardless of the cause of death, is designated as an infant death. Mecklenburg County's infant mortality rate has been trending slightly downward over the last decade, with our rate actually being lower than the state overall as a county overall. And really, in some cases, in recent years, we've actually been lower than the national average as it relates to infant mortality here in Mecklenburg County. This is overall. I'll talk a little bit about some of the differences that exist among subgroups here in just a minute. If we were to look across the state and look at overall infant mortality rates by county, you'll see that Mecklenburg's infant mortality rate overall, which is about 5 per 1,000 live births, which in whole numbers, that's about 75 to 80 infant deaths per year. Mecklenburg County is about on par with where Wake is, and actually a little less than Guilford and Forsyth counties, which are other large counties in the state. And this map in the corner shows you the dark purple counties have the highest infant mortality rates, some as high as 20 per 1,000 live births. And you'll see that we are on the lighter end in terms of the shading in the county overall. As you will recall from the board retreat that we had earlier this year, this pattern is not true for all folks in our community. If we look at this by race and ethnicity, we see pretty stark differences between our non-Hispanic Black residents and our non-Hispanic white residents, in particular, with the death rate among Black residents being more than about 3 times as much as that of the non-Hispanic white residents. And if you remember what I showed earlier, that county map, the rate for Black residents is about 2 times higher than the overall county. That rate is improving gradually, but it's a very slow improvement over time. If we look geographically across the county, and this is really important, we do see differences by zip code and where infant deaths occur. But certainly we see, there is a higher rate of death in what traditionally is deemed the crescent, but you'll see that there are infant deaths in almost every zip code in the community. So it's not exclusively in low-income neighborhoods. They do occur across the community. And it is an important distinction to make, because for many of our health outcomes, we see really, really wide gaps, but we do see these differences in some ways, regardless of individuals' income. So what's causing the deaths? This graph here shows you the leading causes of death for infants from 2015 to 2019. You'll notice that some of the data here are a bit outdated because we've been in a year-long battle with the State Center for Health Statistics to be able to actually get our death registry back to us. And so it's thankfully some progress has been made there, but unfortunately we've been struggling to access that information that goes to the state and get it back to us, which you'll see is the theme for the day. But nonetheless, we're making some progress in that direction. The majority of infant deaths, though, are related to perinatal conditions or congenital malformations or birth defects that are present at birth. Most of these infants who have perinatal conditions typically have some perinatal outcome that's driven the individual baby to have some risk, and that usually is mom has either had the baby too early, so it's a preterm birth, or there's been some complications throughout the pregnancy that's caused complications for the infant. About 6% of the deaths are unintentional injuries, which includes deaths due to assault and suffocation, which most commonly are those deaths that are related to unsafe sleeping environments. So these are kids who are in cribs or not in cribs or in beds with their parents, sleeping on couches, for example, and the child inadvertently rolls over and suffocates, or the child spontaneously does not wake up for some reason, or we may not be able to determine what actually caused it, which I'll talk a little bit about later on. But those all get captured in unintentional injuries. And then there's a whole host of other causes. And unfortunately, in Mecklenburg County, we have had several infants who died by assault or homicide. And in the last 5 years, I believe there have been 5 of those deaths related to homicides. As I just mentioned, low birth weight and preterm birth are large contributors to the infant mortality issue that we have in the community. So healthy moms produce healthy pregnancies, which produce healthy babies. But if any one of those is challenged, then we end up having challenges with the baby. And so, of course, it's really important for us to focus on preconception health, that before women get pregnant, that they're healthy. But of course, what happens in pregnancy does result in risk for the baby themselves. And so if we look at rates of low birth weight and preterm birth in Mecklenburg County, which are, again, can contribute to adverse birth outcomes, but each alone don't necessarily cause infant mortality. We do see a really large difference a similar difference between Black and white families in Mecklenburg County. So you see where many more Black infants are born preterm or at low birth weights, which of course are related to each other. And you see that difference very clearly for our Black residents compared to the white residents. Just to point folks' eyes to the colors, if you can't see it, the Black residents is the gray bars here. Overall is blue, and the orange bar is non-Hispanic white, and the bright yellow is the Hispanic population. One of the important contributors to having a healthy pregnancy, of course, is prenatal care, not just accessing prenatal care, but the time at which a person accesses prenatal care and ensuring that they actually utilize that prenatal care to its full extent. And so we are able to track via birth certificates when families are able to get access to prenatal care. And in Mecklenburg County overall, about 70% of families access prenatal care within their first trimester. If you look across racial groups, actually access during the first trimester is worse for our Hispanic residents. But also you do see a disparity there between our Black residents and our white residents in terms of folks accessing prenatal care within the first trimester. The second two categories here look at the adequacy of prenatal care. So is mom getting into care on time? And then are they actually making 80 to 100% of their visits while they're in care? And you can see, again, there's still a disparity there for our Black residents in terms of care. And so this is important because these are the issues that we focus on as it relates to trying to address infant mortality, is again, trying to get folks into prenatal care on time and making sure they have adequate supports so they can utilize their prenatal care and it can be adequate. All right, as I mentioned earlier, preconception health and reproductive life planning are key factors for improving infant and maternal health outcomes. Again, a healthy mom sets the stage for a healthy baby. And we see if you look at the birth data of moms in Mecklenburg County, more than half of moms don't have a healthy pre-pregnancy weight before they get pregnant. We still have about 1% of our moms who report smoking during pregnancy, which we know creates significant complications. And about 8% of moms experiencing gestational diabetes and 2% experiencing pre-pregnancy hypertension, and many more experiencing hypertension during pregnancy, all of which contribute to a family's risk of having a preterm birth, which of course then contributes to the child's risk of having complications in the perinatal period. I just want to explain a term to you. Sudden unexpected infant death is a term that we use to describe when an infant that's under the age of 1 dies from a cause that we really can't tell what the cause is. There's no defined area. Most often these are deemed, when the child death review team reviews these deaths, they are classified as sleep-related deaths because the kids are either in cribs that have stuff that shouldn't be there, like lots of blankets or excessive bumpers, or again, they're sleeping in an environment in bed with their parents on a couch that's not safe for a small child. In 2020, just taking 1 year of data, we had about 11 sudden unexplained infant deaths in the county, and the majority of those were among non-Hispanic Black infants. And again, this is a really important opportunity for us to intervene by just simply providing a safe, healthy sleep environment for kids. Breastfeeding is also an important factor that also could help protect kids from having some short and long-term complications and illnesses. And it's really important. Breastfed kids have a lower risk of asthma later on in life. They have lower risk of other complications at birth, other viruses and other types of bacteria that can be exposed. The benefits of breast milk to those kids in terms of their immune system are so great that it can actually help them avoid other kinds of illnesses that will produce the risk of death for the child. In 2020, about 90% of our moms reported breastfeeding when they left the hospital, which is very high and higher than some other communities. However, it's really important to note that this number drops off pretty significantly after the child is brought home, with many moms not continuing breastfeeding or not continuing full-time breastfeeding. And so it's important that we have adequate supports in the community for moms as we think about their ability to be able to breastfeed their children. There are also a whole host of other factors that I'm not going to talk about today related to infant death. I just wanted to note that obviously the social economic determinants and people's healthcare experiences, racism, et cetera, can all negatively impact the health of the mom and the baby. That can ultimately contribute to the disparities that we see in infant mortality as well as maternal mortality. But we really need better data here locally to understand the experience of mothers. The role of racism, for example, and a mother's healthcare experience in their outcomes and their infants' outcomes are well established in the literature and nationally, but we don't have a great understanding about what's happening with moms here because you don't have a system to really monitor what's happening to know how much of a problem it is for us in Mecklenburg.
You're not speaking loud enough when you finish.
Okay, I will do my very best, all right? And you just lift your hand if you can't hear me. I'll try to keep it as loud as possible. We have a number of services in the health department that work to address and support new mothers, pregnant women, as well as infants. And so this diagram kind of helps to categorize the period at which we deliver those services to families. And I'll spend some time talking about all these programs in some level of detail. But you can see we do have some efforts that occur. And these are services that we deliver directly as a department. There are other initiatives that you're going to hear about later today from Genevia that we support as a county, but we don't actually deliver them or operate them ourselves at the health department. So our family planning services, we provide low costs. It's on a sliding fee that slides to zero. So comprehensive family planning services at our Southeast and Northwest clinics. We will be also having family planning services at the new CRC that's opening in July. We include reproductive life planning. We have a whole host of device implantation options for families in terms of contraception. We have pharmaceutical contraceptive options. We also have emergency contraception, and we do pregnancy screenings at the health department as well. Each year, we identify about 150 to 200 pregnancies among our clients that we serve directly. In fiscal year 19, we had about 5,000 unique patients who came in for family planning services. Obviously, the majority of them are women. The majority of them are Black and Hispanic, and they produce about 7,000 visits a year, which is, we use 2019 data because the last 3 years have been really, with the clinics being closed, there's been lots of fluctuations in our service delivery, but we are returning back to these levels of service in FY23 for sure. And actually in some cases more. Another program that we operate that is very specifically focused on pregnant women is the Medicaid Care Management Program for high-risk pregnancies. This program is intentional. It's a Medicaid program that's supported by the state. It's been around for quite some time. It's in every county in the state. And essentially it's focused on serving those Medicaid moms who are highest risk. Eligibility for the program is determined based on a risk algorithm that's given to us by the state. And we receive referrals from all the Medicaid plans directly from the OB practices, as well as from hospitals or birthing centers. And we also can receive referrals directly from the community. This program is staffed by about 20 care managers who are either nurses or social workers. And uniquely here in Mecklenburg County, these care managers are actually embedded in the OB practices, the obstetric and gynecology practices in the county. They actually sit in their clinics. Many of them have offices in those clinics where they can directly provide support to pregnant women that are coming into the OB practice for prenatal care. And they can also link clients who are referred to them directly to those practices for care, depending on where they live. Every month we receive referrals directly from the Medicaid managed care organizations with rosters of patients, and our team works to enroll them. And then again, like I said, the care managers provide a whole host of wraparound services. So they help keep them engaged with prenatal care. They provide connection to other services in the community. And they also provide tangible resources like cribs and car seats as well to those families. We serve about 1,800 folks in SimHARP on an annual basis. And we have capacity to probably serve more depending on obviously the demand for services in SimHARP. Another large, again, mandated program that we operate that is a state initiative that exists in every county is the Women, Infants, and Children's Program. WIC provides nutritional education for families. It provides lactation and breastfeeding support and supplies, including pumps, as well as educational materials. And of course, everyone knows WIC provides supplemental nutrition to families as well. So we provide a whole host of food items to supplement what the food that's available to those families, including formula for those kids. We have an emergency formula process as well. So if a family comes to us sort of late in the game, once the baby's born, we do have formula available at our locations for immediate distribution as well. You can see here the eligibility criteria for WIC. Any one of the, they have to be a North Carolina resident. They have to live here, but they don't have to be documented. They do have to live in, they have to claim North Carolina as their residence. And then they have a whole host of eligibility criteria based on income and other programs that they're eligible for that determine if they're eligible for WIC or not. Oh, sorry, I'm doing the best I can, y'all. I knew this was a bad idea. Okay, about half of the women who receive, about half of the pregnant women receiving Medicaid enroll in WIC during the prenatal period. So about half of the Medicaid moms in the county join the WIC program while they're still pregnant, which is great, right? Because it's better for us to engage with them earlier as possible in the process. And we have a whole host of resources that we can give them through WIC while they're still pregnant, including supplemental nutrition, and also helping them get ready to breastfeed, for example, getting the pump to them, providing additional support, as well as connecting them to other services. And you can see here the period in pregnancy in which those moms are enrolling into the WIC program. Again, we get a large number of them, about a third in the first trimester, 40% in the second, and the remaining in the third trimester. Another state initiative that we operate here is improving community outcomes for maternal and child health. This is a collaborative effort with Union County. It's a state-funded initiative, and it provides a whole host of systems level trainings for addressing maternal and child health outcomes in communities. And so the goal here really is to ensure that individuals who are either going to be pregnant or could be pregnant are aware of have all the necessary tools it takes, and that the providers that serve those individuals have tools to be able to provide resources to their patients. And that includes, they do a positive parenting program, they teach a curriculum on reproductive life planning, there's a mothers and babies program, which is an educational program for new moms. And then also ICO for MSAGE provides lactation support in the community as well, and they train lactation consultants. Also, there's a care management for at-risk children. It's another program that is a Medicaid program that we operate. This program, similar to the care management for pregnant women, also is staffed by social workers and nurses. These social workers and nurses, though, are embedded in our WIC clinics, as well as they are sitting in many of the pediatric the hospital's pediatric outpatient offices. Similarly, they have seats in those offices, and they provide direct care to those patients. This program does serve kids up into the age of 5, but I included it here because any child who's born prematurely is eligible for CMARC. And so if a baby's born prematurely or they have a NICU stay, then that child becomes eligible for the care management services. And care management, again, is about connecting families to all the needed resources that they might need. And so it goes well beyond what we offer in public health and HHS to really making sure that families are connected to resources to address their overall whole health needs. There are about 4,400 kids actively enrolled in CMARC on any given month. And I think this is getting close to the end here. The Children's Development Services Agency is similar to CMARC in that it is a program where eligibility is determined by having a NICU stay. So if an infant is born prematurely or at a really low birth rate or with some perinatal complications at birth, those children are still eligible for CDSA services as well. CDSA really seeks to be an early intervention agency. So if children who are born prematurely, for example, are at greater risk of having developmental delays because they didn't get to stay in as long as they needed to. And so CDSA works to make sure that we are intervening early on those kids from birth to make sure that they are developing on schedule. We receive referrals for CDSA from the community as well as from a whole host of other providers. And we enroll about 1,200 kids on an annual basis, again, between the ages of 0 to 3. And CDSA, again, we're one of the 16 CDSAs that serve in the state of North Carolina. CDSA provides an array of intervention services. So from speech language therapy to physical therapy to make sure the baby's crawling and walking on time, to screening for autism and connection to care, to also providing, now we are going to be providing behavioral health services to kids as well. So the service array in CDSA is pretty exhaustive. Once a kid qualifies for services, it is a pretty intensive wraparound up until the point that they turn 3. One of the things you'll notice is a lot of the programs, as I mentioned, are driven by the state. And so we've been working over the last several years with the support of the Board of County Commissioners to really evolve our data systems as it relates to maternal and child health. And so about 1.5 years ago, we did hire a dedicated maternal and child health epidemiologist to be able to expand our capacity to track outcomes, as well as to determine or assess our impact across these multiple programs, which currently all operate independently because of the way they're designed by the state. They also have separate data systems that don't talk to each other. And so as we think about looking at our overall impact, not just in public health, but as HHS, having some analytic capacity to help us do that, to tell a more comprehensive story has been part of our goal and that we're working towards very aggressively, but it is a thing that takes time. One of the things that's a barrier for us is again, many of those systems that we operate are owned by the state. And so we have to go back and forth and sign agreements and fight with lawyers and do a lot of very difficult work to be able to just get access to basic things, including our death registry, as I mentioned earlier. We are really excited, though, that after 1 year of debate with lawyers, we are going to get our monthly birth and death files back from the state, which has been a very huge headache for us over the last year. We're also completing a perinatal superior risk analysis, which is a CDC standard for communities as we think about how to address infant mortality. And we're also really excited to be now negotiating a contract with the state to oversample their pregnancy risk assessment monitoring system, to allow us to be able to actually understand better what the mother's experiences are here in Mecklenburg County, which today we can't do that very well. And as I mentioned earlier, our epidemiologist is working to combine a lot of data from all these multiple programs so that we can start to quantify our collective impact across these programs. And then this team also provides extensive support to the child death review team, which does review every child death in Mecklenburg County. So every infant that dies, that team reviews all the circumstances and produces a report every 3 to 4 years on recommendations about what we should be doing to address it. Lastly, two more things, and I'll get out of the way. The service connection pilot that we're working on in this fiscal year, as I mentioned earlier, about 200 pregnancies are diagnosed in our clinics every year, meaning a woman comes in either for STD test or for a family planning visit and she finds out she's pregnant. One of the things we've been working on is to ensure that we are closing the loop with those women and we have optimal delivery of care when they come in, and that they're getting connected to all the programs that they're eligible for as a result of the pregnancy early on. And so it's a quality improvement initiative that we're working to really make sure that this is a closed loop linkage here to those services. We have a memorandum of understanding with Atrium to assure that our patients can receive no cost prenatal care in the community. So that exists. And so they are a provider of choice because of our agreement and them being the former public hospital. We also have an economic services worker who sits in our clinics so that they can actually get these women connected directly to Medicaid immediately when they come in and find out that they're pregnant, which is of course an eligibility criteria for Medicaid. So there's a worker who sits there who can help them fill out their application on the spot. Of course, once we transition fully to CRCs, this will be a different model, but today we still exist in our own clinics, and so it's important. And then WIC is co-located inside the clinic as well. So again, if they come in, find out they're pregnant, of course, we talk about all the things they need to do once that happens, but they can then quickly get connected. And we want to just make sure we have a closed loop there with all of our internal programs and then some of our community-based initiatives that are critical partners for pregnant women. And lastly, as you've heard, this is not only is this area issue a priority for the board, but there has been a committee working for the last 2.5 years on a set of recommendations for the county to consider as it relates to improving the prenatal to 3 system or ecosystem in the county. And so there are a whole host of work that's happening in this space. that will help us, I think, connect more of the dots that are some of the programs I talked about today, but also programs that exist outside of the public health department to again improve this entire system of care. And we're working to again bring on some additional staff persons to help us with the implementation of this work. And you guys heard about this from Tim Gibbons at your board meeting about a month ago. And I'm sure there'll be more updates coming in the weeks and months to come. I think that's everything I got. I will stop.
Thank you, Dr. Washington. I'd like to, pause for a minute and see if the colleagues have any questions before we bring on the other person, unless you think the presentations are so similar that the questions will be about the same.
No, they're different.
All right, so let me call on my colleagues right now. I have several questions, but I'd like to call on my colleagues, Commissioner Leak and then Commissioner Powell, and then I'll follow it up. Commissioner Leak, please.
Thank you so much, Mr. Griffin. Thank you, Doctor. In looking and listening to your presentation, all of this information needs to be presented to the school board, and they're dealing with children, and they're talking about the problems of mental health. This would be a recommendation that I would make, that the staff with the school system, school board itself, have a copy of this report and a presentation from Dr. Washington to clarify programs already in place that the system can utilize if they use them. I'm not sure they're not even aware of what we actually have as a county that is in place to work with our children. All we hear is we need mental health support, but to actually know what the county can and is providing is important. The second piece to this is that the general public needs to know this. And my question is, could at some point, and especially in my district, I will set up a meeting, hopefully at Valerie Woodley Center for the Community, or either West Charlotte Center, to hear this report, and especially young mothers and families. So I needed to say that. If I'm out of order, Mr. Griffin, let me know. And
No,
the
ma'am, you're not.
last thing is the word family for Black people. I always go back to years ago when the congressman from New York wrote a book about the Black family. Watching a program just this past week as it related to Black males being fathers, who then becomes the head of the household. These are major problems that we have that we must address. And to sit and act like we don't have these problems is a problem in itself. So how then can we manipulate to get this information to the general public as well as the school system? This report that this young man has written, this is an excellent report. It's first class. I want to commend you for the report, son. I have not seen anything this in-depth as relates to the family. And here we have the issue before us in this country now on abortion. So all of this is in place. And my concern is, how do we address these issues as a board and as a community and as the health department? Thank you, Mr. Griffin.
Thank you, Commissioner Leak. That was Daniel Patrick Moynihan who you're referring to.
Yeah,
out of New York.
I know exactly what I'm talking about.
And it's also a piece that was done in the 80s called The Vanishing
That's
Black
right.
Families. Commissioner Powell.
Thank you, Mr. Chair. So I would like to, I have many questions, but I'm going to focus on two categories. And the prenatal care is, let me know if you think that is significant, because it seems so significant to look at. And I'm looking at slide 8. When people are starting to receive prenatal care, and in my experience, I have kind of a preemie trauma stress disorder myself. I had a 3-pound baby, and he's alive. My son was 3 pounds when he was born, and it was very traumatic. All the experience that I have in healthcare probably saved his life, because I kept thinking, like, I don't feel right. So I had prenatal care and I just didn't feel right. And then one doctor would say, well, go lay down. And I thought, I need to pursue more, like something's not right. And so when I look at, some infant mortality, I think they gave me my last rites. It's such a miracle that I'm alive and that he's alive. And so then I think about people that have no experience in healthcare, that don't have any access to prenatal care. And so it's hard for me to verbalize, like,
Sure.
what are we doing to really wrap our arms around people as soon as they find out they're pregnant?
Yes. So two things I'll say. One, what you're talking about is unfortunately the experience of a lot of moms in a lot of communities. And that's part of one of the things we need to be able to tell more comprehensively, so people understand that it's happening in our community. We hear about it on the news. Obviously, there's been a lot of attention around maternal mortality in the last week, but it is people's lived experience that we need to be able to articulate what it is and be able to combat against. Our ICO for MCH team does an extensive amount of education among healthcare providers. And so they go talk to a lot of nurses and staff and do trainings on every topic that's related to implicit bias, in partnership with AHEC, Charlotte AHEC, to be able to help educate providers on their own bias that they bring into the healthcare setting, and the role that might play in outcomes for a patient. That said, there's still a lot of opportunity, I think, to continue to provide extensive education, and to your point, to wrap our arms around those folks when they go into the system, so they have advocates and support. And so I'm not going to steal Genevia's thunder, but a lot of what she'll talk about is, and similar to the SimHeart program I talked about, those care managers really become a line of defense for moms. They become their voice, which is why it's fantastic in Mecklenburg that they actually sit in the practice, which is not the case in every other county. That we've leased space in the OB practice so that the care manager can be there as a part of their care team with their provider and with the staff there. And they're part of those teams so that they are really another voice for that patient, and then also can help navigate some of the follow through. One of the other challenges we have with prenatal care is it's only as good as you use it as well, right? So if folks getting engaged in prenatal care and then actually meeting all their appointments, you'll see that adequacy cliff where we start to see people not actually going to all their appointments. It's really important that our care managers play a critical role, just like the community health workers at CareWing and the nurses at CareWing, of making sure that women are able to get to those appointments, families are able to get to those appointments, to be able to make sure they stay engaged throughout the process, so that when something is awry, they have a relationship there to call the provider and explain what's happening. And then, again, this whole notion of preconception health is really important. Having healthy people get pregnant is most important, because if you have health issues that are not dealt with going into pregnancy, they certainly will carry forward with you. And so making sure that we do education in the community abroad about, reproductive life planning. When should I get pregnant? Am I ready to be pregnant? Is a really important part of the equation as well.
I agree, but quite often it's like, wow,
I'm pregnant.
here they are pregnant.
Yeah.
And so, that's the reality you have to deal with.
It is.
And I just want to make sure that we're doing a good job messaging because, yesterday I was on the phone 30 minutes, somebody shouting about revaluation and the messaging on that. And I thought, I feel like we did everything we could with messaging. And so I hope that we're doing everything we can here. And then on slide,
Commissioner Brown, if I interrupt 1 second, with the prenatal to 3 report and recommendations that are coming, that encompasses the work of the county, all of our health and human services agencies, and our external partners. There is going to be a comprehensive rollout of that work to everybody. You guys have gotten the sneak peek as the commissioners first, but there is a plan to make sure that we are communicating not just the recommendations, but the importance of this issue and the work that we all can be doing together to address it.
and so I'm sifting through all my life experiences because I've worked with so many people in weird situations. And so one of the most recent ones was a really young person who had a normal delivery, but she was young. And so in the hospital, when they were going through breastfeeding, nobody talked to her about checking the wetness of the diaper. And so she would breastfeed what she thought was appropriate. And when the baby was done, but then here, after 4 or 5 days at home, the baby's in intensive care. It could easily be one of these mortality numbers in intensive care because the baby was not getting enough milk and the mother never even knew to check the diaper. She didn't have family support system. And so I thought, wow, on slide 13, how do, we identify the high risk. Oh, no, it's not 13. I'm telling you the wrong number. It's slide 19. How do people know about the CDSA?
So, a whole host of providers have automatic referrals to CDSA, like the NICUs. We are in close contact with all of the neonatal intensive care units in both of the hospital systems so that they know to send referrals to us when babies are born prematurely or have a NICU stay. There are a whole host of community providers, childcare providers that we do extensive education with so that if they observe delays, they recommend to us. And then pediatricians, we do a lot of engagement with the pediatric practices because they typically, they're required to, not that they always, actually do a screening of children when they come back for their well child visits. Of course, that means the child has to actually come for the well child visit, but they do screenings at well child visits, which is required by Medicaid and other payers that are good signals for us that triggers a referral to CDSA. And so we do not have a referral problem at CDSA. It also has a very long history. So we do capture. One of the challenges we have is parents who are not engaged with those partners I just described. Many will self-refer, but if they're not engaged with their provider, they're not going back for the pediatric visit, then they could get lost and end up not getting needed early intervention, which is where we start to look at other community partners who engage with those families to help us make sure we're capturing them and getting them into the care that we have to offer.
Thank you.
Sure.
Thank you, Commissioner Powell. Just a couple of questions. There's just so many different activities going on. Every time I see on the news or when Dr. Allen makes a presentation from the enterprise, is what she calls it, and you see, infant mortality deaths, and particularly African Americans leading the way, and from the enterprise again, when you talk about premature deaths, what I'd like to see, and maybe the first step is to figure out this recommendation number 1, which is data collection. Because I'd want to say, let's reduce, because sometimes we talk about the crescent like it's a foreign country, but let's reduce the infant deaths by 50%, for example. And so that will force something to occur that may not be occurring now. And one may be the fact that there are different systems, reporting systems, and you can't talk to each other. But if we started off by saying, I want to reduce the infant mortality deaths in Mecklenburg County by 50% in 5 years, what triggers would need to be pulled?
Sure.
Would be my question, because we can talk all day about strategies from this perspective or that perspective. But if you start off with, let's reduce the infant mortality by 50%, what needs to take place?
Sure. So I'm not going to answer that question directly on the spot, but I will say that is the framework at which we are approaching this collective work today. I mean, that was sort of the impetus behind the Early Childhood Executive Committee that's been the group that's been convened, is what should our goal be? What should be the target here? And what are the things, what are the triggers? And these recommendations really are anchored as those triggers that should be leading us towards the goal. And when you see the full report, you'll see, the first goal is healthy births. We want to have healthy births and kids make it to the first year of life. And so that's the train track we're building on, but we're building it in real time today. And the investment to hire a data person to be able to help us cobble together some of these disparate data systems was step one. But unfortunately, that process is taking much longer than we expected because we've just been fighting with the state about legal agreements to actually have data that we collect and that we see every day for them to give it back to us so that it's usable to be able to provide the kind of outcome analytics that are really gold standard in terms of understanding what impact we're having.
Yeah, my conversations with Mr. Trotman on several occasions, it's like, where do we start in terms of a target? And then from an elected perspective, from a policy perspective, how do we add value to what you guys doing from a staff or administrative perspective in terms of the community at large, or Atrium or Novant, et cetera, to get to where we want to be. So from my perspective, it would be nice to have some kind of recommendation so that we're, not only in terms of what you're doing, but what could we do to make sure that those external resources that you need to have to achieve 50% reduction are at hand if Atrium or Novant or any of these other folk need to do something different would be, and that's just a statement. The question here, because we're into like specifics, what the heck is a risk algorithm? And how do we use that as a county? Is this something new from the state? Or
No, it's been around for a long time. It's required. It is basically the long and short of it's a screening tool. You ask about a set of risk that the mother may be experiencing. These can be both social, behavioral, or health risk. There's a set of questions that are posed there, and there's a threshold that says you're above or beneath. The truth of the matter is, though, our care managers will serve anybody who is needing our help. And so we are fortunate here that while this is a mandated program, it's not, we do have some county investment in it, and so we're able to serve anyone who needs help. And we also receive a separate grant that we have to apply for competitively to be able to serve people who aren't on Medicaid, because remember, this program was established decades ago as a Medicaid program that was run by every health department in the state. And so as managed care is coming on board, we don't know what's going to happen to this, which is another conversation for another day. But this has been around for a very long time with these sort of systems that exist to determine eligibility. We're fortunate because the county supports that program. We don't have to always stick to the eligibility criteria.
Is this just a requirement for you? I mean, for public health, or is this a requirement for
Well,
medical
85.
providers?
It's a requirement for Medicaid. It's an initiative of the Medicaid program that was determined was best implemented by local health departments. So whenever it was started, which I don't know when it was started, the state said, we want to be able to support, this is before managed care came about. This is when we just had NC Medicaid. We want to make sure that our Medicaid recipients are well supported, particularly those that are pregnant. So local health departments, we will give you guys funding to hire care managers to support Medicaid moms, and we'll pay you on a reimbursement basis. So we are reimbursed by Medicaid on a per member per month basis for those that we are serving. Before we had managed care, that was coming from NC Medicaid. Now that we have managed care, we now have a contract with every one of those managed care organizations who actually pay us, the county, to deliver this service to their patients, the clients that are on their rosters. because we have that separate grant and county dollars that go into the program, if let's say mom, A comes to the OB practice at Myers Park and she doesn't have Medicaid, she's undocumented, she's not eligible for Medicaid, whatever the case may be, if she needs our support, our care managers can still care for her in the same way they would a Medicaid mom. We just don't get reimbursed for that care.
One last piece. You mentioned something about the care providers in terms of culture. Well, I interpret it as cultural competency in terms of OBGYNs and pediatricians. You said something, one of the elements was racism out there. In terms of culturally competent providers, is that an issue or is it a need for training?
There it is, and there are a whole host of training activities that occur. AHEC runs a whole host of implicit bias and cultural competency trainings for providers at all of the healthcare, both outpatient and inpatient practices. Our ICO for MCH team very specifically adds in the racial bias component to that in a lot of the trainings that they do of healthcare providers and others in the community. But it is a gap, right? I mean, it is a thing that we don't have great measurement tools to say, okay, 20% of moms are experiencing bias in the healthcare setting when they go to deliver a baby in Mecklenburg County. I can't tell you that today. But part of the reason why we want to have the pregnancy risk assessment monitoring system in place here is so that we can start to collect those experiences. I'm sure Genevieve has plenty of anecdotes similar to Commissioner Powell's story of how she told her provider how she felt and they told her to go lay down. And a lot of women who have those, what I would call negative interactions with the healthcare system, where they're either not believed or not listened to, which we know is a problem. And we know we work, like I said, our care managers serve as advocates, the staff at Caring serve as advocates for their patients. We know it's a problem, but we're not able to quantify that today. But we are still working against it, given that we know it's a problem.
Well, I'm excited about your presentation. As Commissioner Leek indicated, I'm more excited the fact that the team, the enterprise, I guess, will be coming back with specific goals.
Sure.
And then we'll have more conversations about those strategies and support.
One more thing before I sit down, these are a bunch of complicated efforts that have been created over time. And the work to try and to both connect them as well as to try to consolidate some of the duplication in them is very intense and it is time consuming. And it is not something that we have the authority or power to make happen fast, because again, we report to each of those managed care organizations, we report back to WIC at the state. And so we're working, but it is a labor of love that's going to take us time.
But I'm like Commissioner Lee in terms of how do we get information out to the
Public.
broader community about the extraordinary challenges that we have and see how the broader community could help in terms of addressing some of those challenges. I mean, I know it's been a long time. I walked from 6th Street to Blythe Boulevard when it was only one public health building here in Mecklenburg County years ago. So I got that, but today you don't have to walk from 6th Street to that one site. So we ought to be able to do a little bit better. And that's where I want to get the accountability piece on,
Sure.
Can we do better than what we did 40 years or 50 years ago?
Sure.
So that's really important. So
Well,
I
I'll
want
come
to
back.
thank you, Dr. Washington. I apologize for your voice
Yes, sir.
and you're recovering from your with the health issues. But thank you so much. And just stand by because I'm sure there may be other questions as we hear from this young lady who will have a presentation in the same category, but maybe a little bit different.
All right, well, it's always.
We, before you start, Ms.
Yes, sir.
Montgomery, one of our members has just come and I'd like for her to introduce herself.
Thank you, Mr. Chair. I'm Laura Meyer and I represent District 5.
Thank you. Ms. Montgomery, welcome and thank you very much.
Thank you. It's always good to start off being called young. Right. So thank you, Commissioners Griffin, Leek, Powell, and Meyer, and our Deputy County Manager for the opportunity to present to you today on the state of county-funded maternal child health programs with Caring. As you heard from Dr. Washington's presentation, racial and ethnic disparities continue to exist as it relates to infant mortality, preterm births, and low birth weight. This is not an issue that's singular to our county, but one that has plagued our nation. With all of our advances, really proud of what we've done here in Mecklenburg County. We know that women are twice as likely to die from complications of pregnancy and birth than her mother was a generation ago. We've seen a 40% increase in maternal mortality, and that's been cited for 2021. But because of the county's continued diligence, you heard of all the work that's underway now and your determination to combat that crisis, I'm here representing our organization as a part of our collective efforts as a community. We partner very well together and over the last decade have made tremendous progress. We stand in partnership with public health, and we are incredibly aligned to the desired outcomes and the intentions as it relates to services provided to this targeted population. So as the problem grows, not only in volume and complexity, Caring is able to help fill in some of those gaps that Dr. Washington discussed. And that's through 2 strategic programs, Nurse Family Partnership and a Guided Journey. NFP, as we'll refer to it from here, has been a part of our organization since 2008 and has served nearly 1,800 families since that time. Beginning with trust and ending with extraordinary outcomes, this national multi-generational best practice approach empowers vulnerable mothers, and it has transformed lives. NFP succeeds by having specially educated nurses visit the family's home weekly, starting in early pregnancy and continuing until the child's 2nd birthday. The joining of the relationship that nurse creates and the evidence-based curriculum that it offers makes for a very winning combination that results in measurable and long-term outcomes for the entire family. Commissioner Leek, I heard you mention family, and that's what this program is about. Having been studied for over 45 years now, NFP children longitudinally are significantly less likely to suffer from child abuse and neglect, experience fewer ER visits for accidents and poisonings, experience behavioral and intellectual problems at a lesser state before the age of 6. Moms enrolled in NFP experience fewer convictions and pregnancy-related chronic conditions, and they have an increase in their employment tenure overall. Those are all returns that as a society we view as investments, and they can easily be captured at the federal, state, and local level. In understanding the growing need in our community for maternal child health services, our county also made a very conscious effort to solve this problem by offering an alternative to an already existing program. So this new and strengthening profession of community health workers has been critical to helping solve this problem. Caring's been a home to a guided journey since 2021, and we are approaching the 3rd year, and we are hoping to continue to grow this safety net for the Safety Net program as these specially trained community health workers support families with increasing their access to care, connecting them to needed resources, and promoting healthy lifestyles to the provision of culturally sensitive education. One unique aspect of a guided journey that served us very well in the last few years has been our ability to also enroll up to 3 months postpartum. That is something that Nurse Family Partnership does not offer. So we're able to kind of catch those moms that might be in high-risk OB units and have delivered, or moms that simply weren't aware of the program until later. Overall, a guided journey has been a perfect complement to NFP, both serving the same population. As a result of this addition together, we have been able to widen opportunities to serve and broaden our reach overall for those who may not qualify for Medicaid or who are not covered for services under NFP. Both programs, again, have a whole family approach. We engage dads, we engage grandma, we engage cousins, friends that may live in the home with this model. Both programs also offer low access barriers to acquiring services. All you have to be is a resident of Mecklenburg County, pregnant, and have the willingness to participate in either program. A referral is not needed from another entity or referral source, and we've provided many very easily accessible options for self-referrals, either on our website or by calling or inquiring with one of our referral options. Both programs are also thriving, having served a combined 1,024 families last fiscal year, and we are projecting similar outputs for this year. Lastly, for this slide, the supervisor for both programs are overseen by our Director of Maternal Child Health, who is a woman of color and arrived to us with 3 decades of experience in this area. Her programmatic expertise has been a tremendous value to both programs as we both launched A Guided Journey and expanded NFP. As shared earlier, our efforts are incredibly aligned with the counties in that we're striving to achieve better health and well-being for our families during their prenatal to 3 journey. As you'll see on the screen, akin to our public health partners, we are providing services that assess for and monitor things like perinatal conditions, preventing unintentional deaths due to assault and injury, unsafe sleeping conditions, assessments, and environment. We're looking to improve opportunities for early and adequate prenatal care, ensuring access to family planning education and methods through our low-cost clinic, which is also partially funded through the county, encouraging tobacco and substance use cessation, helping to manage chronic conditions. Some of our moms arrive to us with diabetes or hypertension complicating the pregnancy. We support breastfeeding initiation, and we also are accessing and providing for social determinant of needs. We recently celebrated a large grant that we received through LISC Charlotte, which is allowing us to provide transportation services to our families in any of our programs, but it has been especially impactful with our maternal child health programs because we're getting moms to their prenatal visits that they otherwise might miss. We accomplished these outstanding results. We'll start with NFP first. You'll see later some of our results on a slide, but our 27 passionate and amazingly skilled multidisciplinary team members serve on a total of 3 teams with NFP. Team 1 and Team 2 are our original teams, while Team 3 was afforded to us through round 1 of ARPA funding. So thank you. This expansion brought NFP to its full capacity, but only for those who qualify for Medicaid. There's an additional assessment if we wanted to include moms that do not qualify for Medicaid, which would warrant further expansion of NFP. But here we use these 7,000 women who qualify for Medicaid and are also only first-time moms. We at CareRing do have a special advantage over other programs in North Carolina in that we are able to serve what we call MOLTIPs, or moms of multiples. That is a very, very unique aspect of our program here, in that we've learned that having 2 or 3 children doesn't reduce your risk. A first-time mom, yes, you're learning things that you haven't done before, but when you're in poverty, when you are battling some of the economic or social issues that our families are experiencing, we've learned that having additional children adds to that risk factor, so we are able to serve. Currently, Team 1 and Team 2 are at full capacity. Team 3, we've hired our last nurse as of early March, and we are now fully staffed, and they are completing their required training before they begin enrolling their families. We anticipate that we will be at our full capacity serving 500 moms just with NFP on or before January of 2024. Once at full capacity, since 2008, we've shown not only in strength in our recruitment for families, we don't have to advertise. A lot of our recruitment is through word of mouth because of the experience families have had, but we also have very good family retention. Our moms are staying in our program at rates of 95 and 96%. They do not drop out, and that's very critical. Moving on to A Guided Journey. We recently adjusted the staffing structure to mirror that of NFP and what we found with other community health workers supervisory models. The community health workers that staff this program are certified through the state's certificate program, followed by a very intentional perinatal and postpartum training that is with the University of South Carolina that Public Health has set us up with. Another unique aspect of A Guided Journey is how it was intentionally built to support the needs of those residents in our priority health zip codes. So I heard you talk about the Crescent, which I believe under HEAT has only expanded, but we are serving more than half of our patients with A Guided Journey who live in those zip codes. The others are narrowly bordering, right? Mom might live in 28208, but her child goes to daycare in 28216. So we've been flexible in that aspect. And Commissioner Leak, before you ask, we currently have 150 moms that are getting services in the most powerful district too. The community health workers that serve,
I didn't hear what you said. Say that again.
we have 150 moms that are in your district that are currently receiving services.
That's where the power is.
That's it, of course, of course.
All right, let's keep it moving.
The community health workers that serve those residents in those zip codes, we intentionally hire them because they either live, work, worship, or play in those communities. So they're familiar with where moms hang out. They're familiar with the informal leaders that we know we need buy-in from before we go into that area. But that's helping to establish immediate relatability and to build trust. You'll also note that both programs offer bilingual staff. They have administrative assistants who are working collaboratively together to use a decision model as to which program a family might be best fit for. We worked with public health and with our national service office with NFP to ensure that this decision model was sound. Those mothers who have more clinically complex needs, that have perinatal conditions, chronic diseases, we're typically referring those moms to NFP. However, those moms that either don't qualify for NFP, we don't have capacity with NFP, or they simply want a lighter touch, those are the families that are going to a guided journey. But there's flexibility in both of these models. A mom can transition from one to the next depending on her circumstances. But what we have found is that once that relationship is established, mom doesn't want to leave. She's going to stay where she is, and we can utilize the expertise with one or other programs to make sure that that mom's care is whole. But that client choice is very critical to the services that we're offering and is integritous to a community-based model. Moving on to the next slide. Briefly, we'll just review performance. I know you have these slides. Just know that these outcomes that you see have been sustainable over the last decade and a half. NFP is sound and it's strong. And because we adhere to this model with true fidelity, we are able to achieve these outstanding outcomes and outputs that you see. This is just a sliver. We measure all the way down to smoking cessation. We measure mom's employment tenure or her ability to return to school. We have pages and pages of data that helps to demonstrate the value of this program. And then here are just a few of a guided journeys outcomes. Although it only launched recently, we have seen very, very impressive tangible results that we are celebrating. You can find the 1 year a guided journey report on our website under their tab. The community health workers have found the ability to quickly connect with these families, and they have served as a bridge and a liaison to some of our large systems, which to an earlier point are often very difficult to navigate for families. So we are using our support that we offer, our voice, we're helping to advocate to make sure that families have exactly what they need. But no success is without trial. You heard Dr. Washington speak on some of the challenges that we also are experiencing with our programs. This is not an easy problem to solve and is evidenced by some of our backwards trends, especially as it relates to marginalized populations. It's fair to say it's an epidemic, right? It's a national crisis. We are treating it like a crisis here in our county as well because of the dedicated resources that you are devoting to solving it. But to put cost into perspective, the average expense for a preterm infant is $114,000 for just the first 6 months of care. If that child is born at 24 weeks of less, that 6 months turns into $603,000 for care. So you can imagine how easy it is to tabulate these societal costs later on as we look to developmental delays, behavioral or intellectual challenges, and just the tremendous impact that it has on a family overall and their ability to have a better way of life. In Mecklenburg County, again, we've estimated that nearly 7,000 women qualify for these services with our programs, but as a result of COVID, we noticed not only did the volume of need increase, but the complexity of care. We know that COVID really did hit some of our families harder as they were trying to battle some of the economic conditions they were under. So we have seen that with our maternal child health programs as well. We are valuing the collaborative approach with the county while we try to solve this very expensive and layered issue. Our heels are dug in, and we're going to continue to be creative in how we identify solutions. One challenge is with nursing workforce, of course. We are experiencing that in every entity of healthcare worldwide, but thanks to the ARPA grant, we've been able to test out a new aspect of NFP, which is practicing with associates level nurses. We had to get special permission. We had to ask, but we were encouraged to do so, to look for a creative solution. to the shortage on bachelor's prepared nurses. So we are testing this out, providing some educational stipend for those nurses in exchange for their remaining with us after they graduate from their bachelor's of science. So maybe they'll become a public health nurse once they're done with us, and we're helping to fuel this workforce. We also are continuing to learn more about community health workers and how they can help impact the problem. Our families are also mostly of color, half Black, and the other half are typically non-white, Latinx, or Hispanic mothers. But we've seen a significant increase in the Latinx referrals. We are over capacity with our bilingual community health workers, and we're working through some of those challenges with public health. But it has become an increasing challenge that we're trying to monitor. Translation is very expensive. So even though we have some capacity with some of our English-speaking community health workers, at almost $2 a minute for translation, you can imagine for a nonprofit that cost is unsustainable. So we're utilizing the staff we have inside of our house to help translate and make sure that a family, if we are not able to serve, gets to a program or partner or agency friend that can serve. We also have been tirelessly seeking Medicaid reimbursement for NFP specifically. Half of our moms have Medicaid, the other half are uninsured, and we are pretty confident that our healthy birth outcomes that they're experiencing, meaning the health plans, are largely due to the support we offer from our home visitation programs, but we receive no revenue currently. We are actively in our first data sharing pilot with one health plan and excitedly looking for others so that we can begin to talk about what reimbursement could look like after they've seen those amazing outcomes that we keep telling them about. We will be one of 12 states currently that offer reimbursement models for NFP, so we're hoping to join. And lastly, as shared, half of our moms do not have insurance, so we are not anticipating a huge impact for Medicaid expansion because our moms simply won't qualify. However, we know that the cost for an unintended pregnancy, an unhealthy pregnancy, or an unhealthy birth is going to cost our community. So we want to continue to look at investments like NFP and a guided journey to help mitigate that problem. All right, looking at our last slide, which is collective impact. We're speaking about investment, so know that we are grateful for all of the intentional seeds that you fiscally sown into our organization, and especially into the creation of a guided journey. It's been a pleasure for us to host, and we are hoping to continue serving and help evolve this new learning model of care. Community health workers is a new profession for us, but again, it's been impactful. We may not see some of these strong clinical outcomes, but as far as addressing social determinant of health needs, helping families navigate care, and just giving them someone to talk to. Sometimes our moms just want to be able to call and say, it's July, I'm 9 months pregnant, I'm hot, and I'm hungry, and this is not fun because I have to take 3 buses to get to my appointment. So having that trust factor has been huge, and we have been able to, through all of our programs, Caring, be able to speak strongly to that. We have also dived into NC Care 360 at a deeper level and are working with Dr. Washington and his staff to learn how we can continue fortifying that statewide platform, because it's giving us a lot of good information and data that we can lean on as it relates to what our families need. And we've also been able to strengthen our hospital partnerships. Our workers are on the units of the high-risk OBGYN areas. They are at the community clinics. They are working very closely with a lot of the partners that Dr. Washington mentioned, because we know that we cannot do this alone. Last but not least, we are part of this collective impact. So again, thank you for all the support that you offer. And you can find stories, Commissioner Powell, on our website. You were asking how we can hear the voice of those being served. We have dozens and dozens of stories from our moms on the journey that they've had with us, the difference we were able to make in their lives for their families and their children. And we currently also have one of our former graduates currently serving on one of our board of director seats with Caring, because we understand the importance of lived experience. That's it.
Thank you. Thank you so much. We got about 12 minutes, and the way I want to do this is 3 minutes for question and answers from commissioners before our time runs out. And I'm going to start with my right this time. I'm going to go with Commissioner Powell, then Commissioner Leek, and then Commissioner Meyer, in that order. Commissioner Powell.
Thank you. Thank you for your presentation. And I'm always impressed with you. So thank you for being so sharp and really on point with everything. Number one question, what is the most important thing that you want us to know?
The most important thing that I believe that I want you to know is that we are incredibly dedicated to helping support the county's efforts to reduce infant mortality, to close the gap on disparities that currently exist. This is not a problem that one entity can solve alone. So it's important to have variation, to have different opportunities for families to select and choose. And that's what Caring's been able to offer with our programs, is to give families the right to choose what intensity level they want and what goals they're wanting to achieve.
How can we help with hospital partnerships?
Well, our hospital partnerships, I believe Caring is a unicorn or Switzerland in that both hospital systems support us in very unique ways and we're able to serve collectively. So our hospital partnerships are actually very strong. We were given permission to pretty much set up shop on Novant's high-risk OBGYN unit. Both hospital systems dedicate funding to our programs. Novant sponsors a whole nurse for us every year. So we are actually okay in that area and may be able to support and assist in learning more about how we can support the counties deepening that relationship.
I hope they can do more, even though they're strong partnerships. I hope that they will be able to do more.
Agreed.
And I love that you keep talking about the cost for the community, but it's also the cost of human potential.
Yes.
And so if we don't have the early intervention, the loss of human potential.
Yes.
Tragic. So thank you for your work. It's really important.
Thank you.
Call me anytime.
Thank you.
Thank you, Commissioner Powell. Commissioner Lee.
Thank you. Again, let me say thank you for your presentation and to say to us that we fully fund your program. I think I saw that someplace here. My concern is the word family. How do we define the word family if we're working specifically with just the women? And that's a problem for me. I want us to have the fathers involved so that they too can be responsible or learn the process of being responsible. And there's nothing in your program that enhance the word family. And no disrespect, please don't take it that way. But you have nothing to say to us that, not you personally, honey.
Yes, ma'am.
But the program does not address the word family. And everything we talk about in Mecklenburg County, or if we're talking about school, we're talking about family. Father, mother, children. Given generation of people, the women, always the head of the household. No training for the men to become a part of the process. So when do we help to break that barrier? And we are the responsible people to do that. And we're not doing it. Going back to Monahan and talking about families, never. And I would hope that your program would be trying to entice that because you are birthing Black males.
Yes. Yes.
But what are you doing with them after they reach 3, 4, 5, and 6 years old? Teaching them how to become responsible individuals.
Absolutely.
Are you with me?
Yes, ma'am. And if you look on this slide, we are a whole family model. So we invite any and everyone in the household. That's grandma, cousins, your auntie, your best friend.
Fathers.
Yes, ma'am. Yes, ma'am. And where the fathers are, you'll see them in the picture. They are participants. We're teaching them about gestation.
I want them to be taught.
Oh, absolutely.
A part of a program.
Yes, ma'am.
That's designed
Yes.
to change behavior.
Yes.
And the reason I'm saying that as I look and listen at the state of this country today,
Mm.
the bloodline of Black folk is being cut off
Yes.
by murder.
Yes.
Just this past week, a 3-year-old baby being killed.
Yes.
So we've got to do a better job as overseers of programs that we say are to enhance families. We
Yes.
have to redefine that word for Mecklenburg County.
I agree.
Commissioner Lee. Thank you so much. Commissioner Myers.
Thank you so much, Mr. Chair. Thank you for the presentation. Just one thing that just jumped out at me when you were speaking were family visits, and I just love that. And I just want to say how important family visits are. You've got to talk to people where they are,
Yes.
and I love that. So thank you. Really just one question about funding. I understand that a guided journey is funded by the county.
Yes.
But the NFP, and I thought you don't take Medicaid, or I thought you were completely, okay. So NFP, is it funded by the federal government? Do we give some, or, because you talked
Yes.
about Medicaid, so I'm kind of confused on.
I'm sorry. Yes, yes. So yes, a guided journey is fully funded through Mecklenburg County. So we're grateful for that. NFP has a heavier price tag. So Team 1 and Team 2, our original teams are about $1.5 million for both teams for funding. And our county currently gives us $250,000 a year for that $1.5 million price tag for NFP. However, with Team 3 and that expansion has been completely funded through ARPA. But this is why we're looking for Medicaid dollars in the long run to help sustain that. Because once those funds are gone, then we are going to need to uphold these programs because they are needed for the county. So coming back to Commissioner Powell's question, what do we need? Of course, always at the end of the day, increase funding because these programs do work. They've been long supported by the county and we'd like to see them sustain.
Have you requested more money in this budget cycle?
We have not.
Okay.
But I'd
And
look for some guidance on.
So,
those, too.
so are there federal grants you can get as well for
Yes,
this?
we are able to get state funding. We receive funding through the Office of Rural Health. We have McPhee dollars that come and they're funneled through National Nurse Family Partnership and then to the state. And then the State Nurse Family Partnership Office divvies up funds. We receive healthy funding through the different foundations, churches, different community partners. It is a very, very diverse revenue model. And we know that we need that just in case one area or not is not as successful. And we recently at our event last week, we had a documentary screening for a film called Aftershock, which talked about the journeys of 2 Black women who unfortunately perished as a result of childbirth. At that event, we had some very important guests that were present, and we talked about the long-term efforts to help to solve this problem and the lack of funding in some areas and how we can saturate in order for us to collectively get to an area where we feel better about what we're presenting, because today it's kind of morbid.
Right. Thank you. I appreciate it.
Thank you.
All right, I'll yield my half a minute to Commissioner Leak. Commissioner Leak, half
Thank you.
of my 3 minutes.
I won't be long. It disturbs me. I'm not mad, but I become very concerned because of my training and exposure. When people will say to me, we'll take people where they are. I understand that, but don't leave them there. You lift them up.
Yes.
That's the only thing I'm saying about Black males in this process. Nobody wants to lift them up. Nobody wants to train them how to be responsible to some degree. That's all I'm saying. Don't tell me anything about reaching them where they are. And it doesn't always take money.
Yes.
Money is not always the answer.
Agreed. Yes.
All right,
Thank you.
Commissioner Leak,
Thank you.
you've used up my time. No,
Oh,
seriously,
I'm
I'm just
sorry.
kidding you. No, we're good. We're all within. I got another a minute and a half.
Yes.
I just want to thank you
Oh, yes.
for your presentation. I'm just excited about this particular topic and waiting for Dr. Washington and Deputy County Manager Trotman and the enterprise expert over there to make that presentation in terms of how do we reduce by 50% and what does it take for us to achieve that in this community. So this has been an extraordinary positive topic, and I want to thank Deputy County Manager for helping us out with that. There are some other phenomenal topics coming up that responds to my call to each of you in terms of what were your priorities in terms of this committee. And I'm looking forward to this committee to make some recommendations to the enterprise. I like that. to the full board as relates to access to quality health care. And healthcare includes mental health as well. So thank you so much. Is there a motion for this committee to adjourn?
So moved.
Is there a second? All right, here the second, any discussion? I will go to a deputy county manager to see if he has any parting announcements for us.
Yes, sir. First, thank you to our presenters. Dr. Washington was sick last week, and while he was sick, he put together this presentation. And Shanavia was on vacation, and while she was on a plane, she put together the presentation. So I definitely want to recognize their commitment to getting in front of the two of you. And Commissioner Leak talked about fatherhood and responsible fatherhood. We, Mecklenburg County, have a responsible fatherhood program out of the child support area that we would love to talk to you about and share data and outcomes that we're achieving with that program.
Topics here.
Yes, ma'am. Well,
Thank you so much, sir.
and lastly, the report on prenatal to 3, you saw the recommendations. I'm hopeful to have that report published no later than next month. And then to come and present to you all the full presentation at an appropriate time, as well as the next steps. And in the manager's budget, there are some items there associated with that report.
I really appreciate that. All of you have indicated that poverty is one of the nexus to a lot of these issues. So upward mobility, economic upward mobility is so critical. So thank you all. We have a motion to adjourn has been properly seconded and no discussion. All those in favor say aye.
Aye.
Aye. Those opposed, same sign. Time to go to your next meeting. Thank you very much.
On time.
On time.
I'm teasing with y'all.
Thank you.
Exactly.